All right, part 2 is going to go over the sympathetic and parasympathetic innervation, as well as a general introduction to the reflexes that we'll go over in great detail in the next 2 chapters. But this is a nice way to introduce them so we can start thinking about them in a more understanding type of way and then go on to mastering them. So again, I just wanted to remind you that the autonomic nervous system does have a pretty large interplay with what's going on in the GI tract. Remember that we have norepinephrine that is going to be secreted by the sympathetic nerves, which is going to be inhibitory on the GI tract. And then the vagus, part of the parasympathetic nervous system, releases acetylcholine binding to muscarinic cholinergic receptors, which in the GI tract, these cholinergic receptors cause excitatory outflow. However, we're going to see that there's a huge amount of activity in each of these different areas, so we'll make sure we have a good understanding of what's going on with each of these areas and what the neurotransmitters have to do in each one. But generally, I want you to remember that acetylcholine is very important because acetylcholine is going to be this main excitatory nervous transmitter. So in this picture, we've got our central nervous system, which is going to provide the central nerves going down the cord, and then those nerves coming off of them are peripheral, as we know. And in the parasympathetic nervous system and sympathetic nervous system, we're going to have acetylcholine released from both preganglionic nerves. And where we're going to differ is in the sympathetic ganglia, we will have norepinephrine released from the postganglionic, where in the parasympathetic, we're going to have acetylcholine released from the postganglionic. So just noticing in the enteric nervous system, the norepinephrine from that system is going to inhibit those areas, especially smooth muscle, mucosa, but we are going to have mainly excitatory acetylcholinergic activity. Acetylcholine will increase smooth muscle activity, and it's also going to increase gland activity. You will see a little bit of an interesting interplay. So if you see here sympathetic, there is a little bit of activity with encouraging smooth muscle movement that has a lot to do with general diarrhea. When people take stimulant drugs, it does increase the speed at which the colon empties. So that's a fun side effect of things like cocaine and amphetamine. Even some people have a sensitivity with caffeine where they have a bowel movement pretty quickly afterwards. Some people are pretty sensitive to that, some people are not at all, but it is true that acetylcholine does cause, specifically through the colon, not through everything, increased bowel emptying. All right, so we already went over norepinephrine. We know that pretty much every cell in the body uses ATP as its power source, so we'll see that on a cellular level. The ATP is needed, especially in regions with pumps that need to run to make saliva or trade sodium and potassium or trade chloride. That's really important in the pancreas and with saliva. And I say it's really important, and I want you to remember that when we talk about cystic fibrosis, that's a disease of chloride transport, and you get really thick mucus, which ends up in the respiratory tract causing repeat infections. But why it is a fatal disease is it causes thick mucus plugs to form in the pancreas, which makes something that digests protein called trypsin. And if there's too much inflammation in the pancreas and there's a mucus plug there, the pancreas starts to digest itself, causing pancreatitis, and eventually it turns fatal. All right, we'll go through all these other ones in the secretory chapter, but again, I'm going to go over just a couple of them. Serotonin is a general vasodilator in the periphery. Serotonin's involved a lot with feeding. It's made out of tryptophan, L-tryptophan, which is contained in high amounts of food. You might know the kind of saying that turkey makes you sleepy. It's because it has a lot of tryptophan in it, which is eventually turned into serotonin. But in general, serotonin is a vasodilator, which means when areas of anywhere in the body but in this chapter, the GI tract need more blood flow, then serotonin is encouraged or helps encourage vessels to dilate so that those areas get the blood they need. Dopamine is a general stimulant. When there's a lot of dopamine in the periphery, it causes that increased GI emptying we talked about. CCK, whenever you see this here, cola, that's referring to the gallbladder. Kinins are a type of chemical messenger. Cholecystokinin, we call CCK. That is something that encourages contraction of the gallbladder, which releases bile. Substance P, you'll remember, is your pain neurotransmitter, so that will be involved in some of these processes. We have VIP, vasoactive intestinal polypeptide. That's released along with CCK to help stop what's going on in the stomach so that the food can be worked on in the lower GI tract and we can turn off acid being created. Somatostatin is another type of stop signal for the stomach. These enkephalins, you might recognize that. Hopefully you do from the pain lecture in Phys 1. Enkephalins are part of our anti-pain response. And you might remember not only is substance P involved in pain, but serotonin is involved in the anti-pain. Bombesin we'll talk about in the secretory chapter. It's just a funny word to say. It's not as interesting as it is to say as it is to learn about. All right, so specifically your innervation isn't that difficult because the parasympathetic nervous system, remember, is craniosacral. So either it's coming from vagus nerves or it's coming from the S2-3-4 unit. So the parasympathetic nervous system, we know it's excitatory. About 95% of the input is vagal related. There are some sacral types of nerves coming out, these pelvic nerves, and they come through S2-3-4. There are some sacral sympathetics there because remember, if we have activity that is parasympathetic, that is going to allow contraction of things. So sacral sympathetics are going to allow some relaxation of different areas so that we can have bowel movements, we can hold our fecal material in rather than having it just come out like it does in infants. So it does have some interplay with the sympathetic system. The sympathetic innervation comes from the T5 down to the L2. Remember, most individuals, it ends at the L2. Some it does extend down to L3, but once you're done with L3, then you're onto the sacral regions. Remember, this is an area too with specialized ganglia. There's the celiac ganglia, and that mainly is sending efferents out to the lower part of the esophagus and then the upper part of the stomach. There's the superior mesenteric, which means above the mesentery, and then inferior mesenteric, which is below the mesentery. Why this is important is, remember, this is the cervical ganglion, the paravertebral ganglial chain, meaning the preganglionic neuron originates in the cord and then comes out and synapses on the ganglia and then sends a long postganglionic neuron out to the organ. The other thing that can happen is that it passes through the chain and ends up on a specialized ganglia. And remember, ganglia is just a body of cell bodies that do the same thing. And that's its first meeting place. And then the postganglionic nerves originate from the ganglia. So the GI tract, that is where there are specialized ganglia, which bring together these preganglionic nerves. And then the ganglia provide a launching off point for the postganglionic nerves. So the superior mesenteric sends projections out to the small intestine and then the ascending colon. The inferior mesenteric sends projections out to the descending colon and also the rectal areas. Okay, sensory nerve fibers. Remember, I'll say it over and over and over again. Remember that stretch is really important. So we have to have stretch receptors embedded in the walls to send sensory information up through these typical sensory pathways we learned about before. sensory information is coming up through the DRG, synapsing on the cord, and then sometimes there's local reflexes that come right back out, or we can have more afferent information going up to the cord. Other things that the sensory nerve fibers sense besides just stretch are irritation. So if there is a huge amount of irritation in the bowel, so let's say somebody had food poisoning, maybe they drank too much alcohol the night before. If there's a lot of irritation in the intestines, your body doesn't want to let more food in. So people will wake up and they might want some crackers, they might want some greasy food or soup when they're not feeling well. And even though they haven't eaten anything all night, their stomach still doesn't want to pass that stuff on because the duodenum is full of these irritation receptors. So then you have food sitting in your stomach. The longer it sits there, the more acid it takes on, and the more likely you are then to vomit it back up. That also happens with excessive distension. So if there is, for whatever reason, it could be due to a food intolerance, which happens when bacteria break down the food instead of your enzymes. So the simplest example of that is lactose deficiency or lactase deficiency causing lactose intolerance. If you don't break down your lactose, then the bacteria in your colon do. And bacteria make gases, so you get a huge amount of distension. This happens in celiac disease, it happens in any kind of inflammatory disorder. So if there's a lot of distension, it usually means there's bacteria, there's air, there is discomfort. So then these tell the body to slow down movement. Also, these respond to specific chemical substances that we'll get into in the later chapters. This is a pretty tightly regulated system if everything is working properly. There's a secretory product for everything. So if you know what the secretory product does, and you know all of them, then you're going to be just fine. Okay, so again, I'm just going to start to introduce these gastric reflexes because there's a lot of them. We will learn about the chemical signals that instigate all of these, but some of these are local, simple reflexes. Some of them are long reflex loops, but this is a pretty simple one. So I talked about reasons why we might slow down the emptying of the stomach or the emptying of the intestines, like irritation or distension. That also is going to be slowed down depending upon the concentration in foods. We mentioned that before. So if the meal is high in lipids or proteins, when those components get down to the duodenum, those sensory receptors there, and there's also chemoreceptors, pH receptors, they send information up through their afferent nerves, which are vagal afferents. They pass through the nodose ganglion and they get to the nucleus tractus solitarius. I'm going to mention this brain region many, many times, the NTS. That is one of the most important areas for feeding in the entire body. The hypothalamus is what drives calorie need, so tells you how many calories you need per day and makes you feel hungry. The nucleus tractus solitarius is how we integrate all of that behavior with what's going on in the brain. So your caloric needs versus what you like, what you want, it's all integrated in the NTS. And that's also where the vagal nerves get together. So this is our simplest reflex arc. It's called the vagal reflex arc, meaning information from these sensory receptors goes up the vagus, coalesces in the nucleus tractus solitarius, and then goes down the vagus to help slow gastric emptying so that we can fully absorb all of these nice things. So sensory receptors, up vagus, down vagus. So this is the vagal reflex, and it tells the body to hang on, don't empty the stomach so quickly because we want to absorb all this goodness. This is the reason why you have a feeling of fullness longer when you eat a food high in protein. Your stomach takes much longer to empty. If there's food in your stomach, it's being stretched and it's telling your nucleus tractus solitarius that you're not hungry yet because you're still working on the food that's in there. So that's your vagal-vagal response, and that you can activate by eating high protein, or you can activate it by taking drugs for diabetes. There's also some longer reflexes. So here what we're looking at is the lumen of the GI tract. So we can have stimuli affect long reflexes, meaning you smell bacon cooking or brownies cooking, or your friend asks you if you want to go get some croissants or cupcakes or pizza, and you're like, yes, I would love to do that. So just that idea of food or the smell or taste of food, that's going to affect your central or your prefrontal cortex, which you think with and make decisions with. And you might think, yeah, I would love some pizza. You plan that activity, and then your hypothalamus encourages it if you're in caloric deficit, definitely. It's integrated with the nucleus tractus solitarius. And then it starts to send messages down to the areas of your gut brain, so that even thinking about food, you actually start kicking on that system. You make acid, you start, your stomach might growl in those cases. We call that the cephalic phase of digestion. Cephalic means head. So just seeing food, thinking food, smelling food, that kind of turns on this system. So it's readying you for food, even if you don't eat. So if you ready this system for food and you don't eat, then you end up with that acid just hanging out in the stomach. For those of you with pets at home, cats or dogs or whatever, if you walk by the treat drawer, you say the word treat or cookie, and the dog thinks like, oh, cookies are coming, I love cookies, and then you don't give it to them, they might throw up and it might look yellow. And that's not bile, that's stomach acid. What that means is they thought cookies were coming, they smelled cookies, they thought, yes, cookies. Their brain told their stomach cookies are coming. Their brains told their stomach to make lots of acid. Then they did not get the cookies. So now they have stomach acid building up, makes them feel nauseous. If they're dogs, they go outside and they eat grass. They eat grass not because it's soothing, but because it encourages vomiting, so they feel better. There's also little short reflexes that we looked at the picture of with the neurotransmitters up here and then looked at here. So the short reflexes are like, oh no, the pH is off, let's not empty any more food out, or we have way too much water down here, let's not empty anything, or there's already food here. So if there's food in the duodenum, it's going to delay gastric emptying because there's nothing else that can fit in there right then. So things from the GI tract stimuli, those are called short reflex arcs because they're just from the sensory receptors down through the cord sometimes. And the long ones have to do with you engaging your brain to actively seek out food because of wanting. Okay. Then there's local reflexes of the gut wall, and these activities of GI secretion, peristalsis, mixing, inhibitory effects, those are all just very basic reflexes that are navigated just by the enteric nervous system running. So one thing I want you to take a look at that we'll talk about more in the propulsion chapter is this is what peristalsis looks like. And this is a great picture of it. So this would have to be in the small intestine. I don't know, maybe this could be the esophagus. That's fine. So you have relaxed muscle, but you swallow something, and now you have a bolus of food. So remember, we said longitudinal muscle just coats the whole muscle. So it's just going to move in a squeezing pattern, like squeezing out a packet of ketchup or yogurt to squeeze out whatever that is, the bolus down to the stomach. The circular muscle has two jobs. Its job is to contract in a band behind the bolus. So that's the lagging like circular muscle band. And then ahead of the bolus, it has to dilate. See that? Because if it was just this big and the bolus moves into that, then that's going to lead to pain. And we see that again down here, the circular muscles contracted behind, and then we have a leading wave of relaxation. So we have contraction behind the bolus, and we have relaxation in front. Again, this is controlled by the enteric nervous system. If this is going too quickly, like in diarrhea, if this happens in the colon or the small intestine, and the piece of food or food remnants, if it's forced into an area that hasn't been dilated yet because it's not working in a slow manner, then it hurts. So then that would be squeezing through this contracted area, and it causes searing pains. The other thing I want you to notice in this picture, this is not peristalsis, this is segmentation. Segmentation is a mixing movement that occurs in the small intestines. So if this person was eating different food products, like they had some avocado and toast, the toast appears brown, the avocado's green, it's down here. And now the small intestines, they are going to take their circular muscle and contract in the center of each of those dilated pieces to mix those things together. And then it'll do it again. So now it's going to contract at the dilated places. And that's a mixing movement. So you'll have circular muscle contracting in front of and behind this bolus. And that's not to move it forward, that's just to mix it up. So the circular muscle does this segmentation or mixing, where the longitudinal muscle will help propel contents forward generally, and the circular muscle can help guide that along by getting our contracted band behind and our dilated band ahead of that. So going through those, we have a couple of different reflex arcs here. We have one of my favorites. It's called the gastrocolic reflex. It causes the evacuation of the colon. So gastro means stomach, and colic refers to the colon, which is the large intestine. So we'll learn that the colon has about 3 big, vigorous periods of activity throughout the day called mass movements, and they respond to your meals. So if you eat 3 meals a day, you have 3 initiations of mass movements. Because typically food just moves really slowly down the colon. It can be in there for almost a day, depending on the person and what they ate. But every time you eat, so the stomach will empty and send food into the duodenum, and the food in the stomach plus stuff in the duodenum will stimulate a mass movement episode in the colon. So the real life implication of that is the most common time of individuals to defecate is within 20 to 60 minutes after their first meal of the day. So you wake up, you have some coffee, you have some eggs and toast. Once that starts to empty, your body says, all right, colon, we've got this new breakfast food coming through. Let's move this food along. So it will move it maybe up to here. And then it's done for a couple of hours until you eat lunch. And then the same thing happens, and we move along, and there's another bowel movement. And then move along, there's another bowel movement. So regular periods of eating help to encourage these mass movements. There's the enterogastric reflex. Entero means small intestine, and gastric means stomach. There are no small intestines on here, just the little duodenum. But once food moves from the stomach into the duodenum, and the stomach is pretty much empty, we now need to turn the stomach off. Because remember, the stomach's making acid. And if there's nothing in there for the stomach to digest, then it's going to digest itself. So we need to turn that off. So the enterogastric reflex is the shut-off reflex caused by the presence of food in the small intestines. So this is easy because it's named for where those things are. Then there's the colon-ileal reflex. So the colon and ileum, which is the last part of the small intestine. Here you can see the ileum going into the cecum, the low part in the first part of the small intestine. The colon-ileal reflex is when there is irritation, when there's distension, when there's backup, when there's anything weird going on in the colon, the ileocecal valve won't open, meaning that food will be trapped for a little bit in the small intestines. So in lactose intolerance and ulcerative colitis and Crohn's disease. That's why there's alternating diarrhea with constipation, because if there's something really irritating, even though there's food stuck in the colon, once that ileocecal valve does open, the watery contents can actually bypass the impacted fecal material. And then the impacted fecal material will slowly move out, which will be painful, but it will look like that patient just had diarrhea. Now, 2 hours later, they're passing a very hard, compact piece of stool. So that's something that you'll see. Some of these are inhibitory, some of these are excitatory. Gastrocolic, that's your pooping after first meal of the day. Enterogastric is turn off the stomach. Colonileal is there's something weird and irritating in the colon. Let's not bring any more new food in. Okay, then we have the defecation reflex. Oh, there's an E missing. Let me add it. All right, so the defecation reflex is one of my favorite reflexes to talk about. And we talk about it also in the motility chapter, but this is quite an interesting interplay. So we've got the sigmoid colon, which is shaped like the final little S, and there's a full 90-degree angle between the sigmoid and the rectum. And that helps slow entry of contents into the rectum, because the rectum is there to receive what's finally ready to be expelled. And whenever the rectum fills, these stretch receptors here, they send a message, see these sensory receptors up through the DRG to the cord, and then they send messages down to these sphincters. So we get the message, hey, the rectum is full, we probably need to defecate soon, but not necessarily this second. So that means that these sphincters will be closed, but that's going to take a lot of sympathetic activity for storage at that time. There's an internal sphincter and an external sphincter. The external one is skeletal, so that goes through the pudendal nerve, and we're in control of that external sphincter, meaning in adults that have been potty trained, there's an additional part of this reflex that when the rectum is full and that message of it being full goes up to the cord and squeezes the sphincter, we then have messages sent up to the brain saying, let's not poop our pants right now. Let's choose to either wait or we need to go right this second. And typically, urge in this case is pretty, not terrible, because the rectum can't hold a ton, and if it's compact feces, healthy feces, they don't stretch the rectum that much. In diarrhea, however, you have a large volume of water entering the rectum, which means the stretch is really exaggerated, so the message up here is going to be exaggerated. So even though there can be a little bit of engagement here with snapping those internal sphincters shut. Usually when that goes to the cortex, people don't have the ability to say, well, class ends in 20 minutes, I'll wait to go have explosive diarrhea. That's something that there's not a lot of conscious control over. So the more intense the stretch reflex, the more immediate there is going to be an urge to defecate. So we'll talk about that more later, but this is one that involves not only the cord and brainstem, but also levels of the cortex that allow you to choose. Okay, again, these hormones you can take a look at here, but we are going to do a whole chapter on the secretory products. So this is something to start preparing you for what will be released in different situations. I should probably even take it out of this for next time, but those are the hormones. We do a whole chapter on them. All right, the other things, just ending the lecture, we talked about peristalsis. We talk about this first in the next lecture also. This is what I just mentioned. Peristalsis goes in one direction. The longitudinal muscle just works to squeeze everything down, but the circular muscle has to have a lagging band of contraction behind the bolus and a leading wave of distension. So this is what it looks like passing through one area, and 5 seconds later, it's now just a couple of centimeters further. The more distension, the faster it goes. The major stimulus, though, for peristalsis is stretch or distension of the gut. So more distension, faster. Less distension is slower. But peristalsis, one way, it is a propulsatory movement. It does not mix anything. It just moves things from point A to point B, and it doesn't go that quickly. It's a nice, slow, normal tonic, slow wave response. I mentioned before the law of the gut states that everything in the myenteric plexus is polarized towards the anus. So the contracted muscle will help propel food towards the anus. The contractile ring starts on the mouth side of your body, whatever part that you're on. A normal peristaltic wave, especially in the intestines, goes about 5 to 10 centimeters, then dies out. And then we have relaxation at the same time downstream to allow the bolus to move on into a non-contracted area. So remember, this is peristalsis. It all happens towards the gut. What is not peristalsis and what does not follow the law of the gut, because it's not moving anything, is segmentation, which is a mixing movement. Again, here you have the colors to let you know what's going on. We have the circular muscle making little bands to mix up food that's in the small intestine, and then the circular muscle in the center of that dilated band will contract to mix these things nice and good. So you can see that there's circular contraction on both sides of the bolus, mixing it back and forth, but this does not move anything in a propulsatory way. It just mixes it up. So you don't need to worry about the law of the gut with segmentation, okay? Only in peristalsis, which is physically moving things. Peri means about or around, and stalsis comes from stasis, which is location. So it's moving something. Segmentation means you're breaking it up into little pieces so that you can get better absorption of products. Okay, finally, the blood flow in this area is called the splanchnic circulation, and the splanchnic circulation is going to involve the circulation to the colon, to the small intestines, but mainly to the spleen and the liver. The liver is the organ that derives the largest amount of blood supply than any other organ during normal circumstances. So if anyone ever asks you that, which organ uses the most blood or the most cardiac output, it's the liver. So the GI tract already uses a ton of blood flow. Adding the liver onto that makes it the splanchnic circulation. 40% of cardiac output during resting conditions goes to the splanchnic circulation. That is why when we go from parasympathetic to sympathetic outflow, we shift the blood flow from the GI tract. So whatever the liver's doing, it's not going to make bile right now. Whatever the GI tract is doing, it's not going to be absorbing products or engaging in peristalsis in the small intestine. It's all going to stop for the time being until the parasympathetic is engaged. So 40% then of cardiac output can be deviated to the skeletal muscle, to the brain, and to the working cells of the lungs so that that person can deal with stress or with exercise. So splanchnic circulation. We'll talk more about the portal vein and its very important role in metabolism when we get to the liver chapter. Okay, here is your arterial blood supply. This is more of your anatomy. But we will talk about this specifically with the villi system when we get to the small intestine. This is a shunt system that's going to allow the tiny little microvilli, which have something called a lacteal at the very center of them. So if you want to picture this like a finger, this would be the finger bone. And the lacteal is a direct way to provide entry into the lymphatic system. And each microvilli, which is on top of a villi, which is on the mucosa of the small intestine, is there to absorb products from what we've eaten and what we broke it down in the stomach, so that we get the direct shunting of nutrients into the blood in the small intestine. As a little preview, the main damage in celiac disorder, when someone has an immune reaction to gluten, they lose their microvilli, so they become flattened. What you see is a lot of diarrhea because we cannot absorb water then through this microvilli, but there's also a lot of electrolyte and like ion concentration, that's electrolytes, and then also absorptive abnormalities because there is a flattening of these villi, which are going to affect absorption. In each chapter, we'll get to local control of what helps to shunt blood to the areas that need it. We do a whole chapter on this, but the autoregulation, that means self-regulation. We don't know a ton about it, but what we do know is that the areas that are highly metabolic at that time, meaning the areas that are dealing with the food products, they're going to require more of the blood flow and the oxygen. Adenosine, which we know is involved in adenosine triphosphate. Adenosine is our generic body vasodilator. You might want to remember this if you're interested in caffeine, because caffeine is an adenosine antagonist, so that instead of getting vasodilation in the brain, we get vasoconstriction. That increases the velocity of blood flow, meaning blood flows more quickly to your cerebral cortex. You can think more rapidly, you feel more awake, you're more invigorated. And then that's also why caffeine helps with headaches, which is associated with vasodilation of cerebral blood vessels. So if you look on Excedrin migraine, for example, there's a large amount of caffeine in there. So adenosine goes up whenever there is arterial occlusion, meaning something blocking an arterial. So that's important because it's there to dilate it so you don't have ischemia. Whenever you digest food, because it rises as a food product, but it's also necessary to deliver the oxygen to that area. And anytime the oxygen goes down in an area of the body. And my question for you was, why would oxygen go down with eating? So think about that, and I'll put up a little question, hopefully, so that we can talk about that. Functional hyperemia. Hyperemia means excessive blood flow. So food ingestion increases intestinal blood flow. We'll learn about gastrin. Gastrin is the main excitatory secretory product for the GI tract. That's why they named it gastrin, like gastric for stomach. Anytime there's gastric, acid goes up, muscular activity goes up, anything GI related goes up. CCK is the gallbladder, I'm getting tired, sorry, secretory product, which is going to encourage the gallbladder to contract and empty into the duodenum. Both gastrin and CCK influence the blood flow because when gastrin is being released, it means that the stomach is active. When CCK is being released, it means that the stomach is turning off, and we're now focusing on what's in the small intestine. And also products of digestion are vasodilators. Just as I mentioned, serotonin is something that's derived from tryptophan, which is in food. So when you break down foods with tryptophan, you make serotonin, which will inherently vasodilate that area. But the rule is with everything in the body, if you're doing more activity, then that area is going to need the blood flow. So adenosine and other vasodilators, but primarily adenosine, they help control that. Okay. Nervous control in certain parts of this area. I will have two questions then to post for you on a little discussion board because I've asked you a question here that I normally go over in class. So nervous control, we talked about sympathetic nerves shutting off things in the GI tract. I'm stretching. Oh, my life is so glamorous. And so it helps shut off splanchnic flow so that we can shunt blood flow, to other places. So that's really helpful. It's also helpful in shock. If you lose blood flow to your brain or other organs, the sympathetic nervous system can come on and shut off any blood flow to the splanchnic areas. But if we think about this, this could also be dangerous. And I want you to think about why that is. So I want you to think about fight or flight. I want you to think about shock. I want you to think about what the Splanchnic system helps do. I want you to think about this kind of buzz term around called adrenal fatigue. And we'll talk about whether or not that's real and why or why not, and what would be evident if that was something that somebody thought they had. So we'll just think about that a little bit. I'll post something on a discussion board later. But remember, in fight or flight, the sympathetic is going to turn off the splanchnic flow, like turn it off. So if you're doing a marathon, it's going to be turned off that whole time. So depending on how long fight or flight goes for, we might have quite a bit of turning that off. So I want you to think about that a little bit. And that brings us to the end. This is a past board question from the physiology section. It should be pretty easy, but do remember that it's also what we just spoke about, which makes it artificially easier. So which component of the circulation receives the greatest blood flow during basal, which means baseline conditions? Is it coronary, so the heart, integumentary, the skin, splanchnic, or renal? All right, so heart, skin, splanchnic, or renal. There's a little bit of a trick question here because integumentary or skin, that's our largest organ. However, the largest amount of blood flow, so the liver is a pretty large organ, but it's not our largest organ, the skin is. The splanchnic is 40% of our cardiac output. The renal is pretty high also. It's estimated between 20 and 25%, but that's not as high as 40. And coronary is not that high at all. It's just the blood flow going to the atria and ventricles of the heart. Okay, so I'm going to post some questions for you later, and I will see you all during my office hours. Feel free to stop by or throw an invite for a new meeting to me on my calendar, and I will see you then. All right, thanks all. Bye.